Hello, everyone. We have a great but very challenging case for you today that's going to require all your tools as both a radiologist and a clinician. But as always, we're going to tackle it in a step-by-step approach that's easy to understand. So a 49-year-old male presents to the ED with 3 days of double vision, a new onset headache, and migraine. This morning, he also noticed his left eyelid appeared droopy. Naturally, a CTA of the head and neck was ordered to rule out acute vascular pathology such as a stroke, which returned to normal. But his clinical presentation is concerning enough that the ED providers order an MRI of the brain with contrast. On the axial T2 flare images, we see there is abnormally increased T2 signal starting in the left periventricular white matter, which continues down into the left basal ganglia, including the internal capsule, globus pallidus, and thalamus. This continues from the thalamus down into the left cerebral peduncle, left midbrain, and upper pons with slight extension across midline within the midbrain. Going back up, we see there is also some involvement of the left temporal and occipital white matter, as well as the left post-chiasmatic optic nerve tracts. On this coronal view of the flare sequence, moving from front to back, we can again follow the optic nerve and better see the increased T2 signal within the post-chiasmatic fibers on the left, as well as the previously mentioned increased signal centered within the deep brain structures and brainstem. So a good next question is any of this enhancing? Take a look at our T1-weighted post-contrast sequence. We can see that we have somewhat patchy, discontinuous enhancement within the previously described regions, including the left optic tract fibers here. Just to compare these side by side, you can see how the flare abnormalities within the images on the left nicely line up with the areas of enhancement on the right, including zoomed-in views of the left optic nerve tract. To finish, let's take a quick look at the diffusion-weighted images where you can see there are some regions of hyperintense signal on the trace images that do not appear significantly dark on the ADC map, likely representing what we call T2 shine-through. No definite restricted diffusion is seen. Finally, on the susceptibility-weighted sequences, it does appear we have some microhemorrhages within the left basal ganglia shown here. So to recap the findings, we have increased T2 signal centered within the left basal ganglia and thalamus, as well as the midbrain and upper pons slightly crossing midline. We have corresponding patchy, discontinuous enhancement within these regions, microhemorrhages, and involvement of the left post-chiasmatic optic nerve tract, mostly edema but with some possible enhancement as previously shown. So we have enough findings to start building a differential, and we're going to start broad and narrow it down as we go. What do you think this could be? Possibly something infectious, right? We definitely have evidence of inflammation, and so we should probably add an inflammatory process on here as well. Infection and inflammation are commonly lumped together, which I find a bit confusing because so many processes cause inflammation. So let's be a little more clear here. What we're talking about is an autoimmune process. Inflammation that is not being caused by some sort of transmittable organism, but by the body attacking itself. We should definitely add neoplastic etiologies to this list, as well as infarct. Remember, subacute infarcts are inflammatory and can enhance, very important to keep in mind. Now, why did we start with these broad categories? There's more to it than meets the eye. It turns out treatment for these etiologies will be different, and our job is, yes, to make the finding, but more importantly, raise the most likely etiologies to consider so the clinician can start the patient on the right treatment as soon as possible. So infectious etiologies will be treated by medication such as antibiotics if bacterial, either supportive care or antivirals in the few viral pathogens we have medications for, antifungals if it's a fungal infection, and so forth. Autoimmune processes will be treated by immunosuppression. If this is cancer, we usually treat with any combination of surgery, chemotherapeutics, and radiation. And if this simply turns out to be a vascular thrombosis, we treat with thrombolytics and sometimes mechanical thrombectomy if arterial, and usually anticoagulation if it's a venous thrombosis. So now that we have these broad categories, let's brainstorm some specific pathologies given the history of this patient and imaging findings, starting with infectious. Could this be a bacterial infection? Or viral infection? or possibly an atypical infection such as TB. If you haven't learned yet, TB is a great mimicker, and you'll almost never be wrong suggesting TB when being questioned by your radiology attending on a complex case. Let's move on to the autoimmune section. What are some autoimmune conditions that can affect the brain and optic nerves? That's right, demyelinating diseases should quickly come to mind. Other things worth considering whenever we have inflammatory weirdness are vasculitis and sarcoid, another great mimicker. Moving on to neoplastic etiologies, this doesn't look like a typical focal mass, but it is avidly enhancing and multifocal or infiltrating looking, so lymphoma should definitely come to mind. Additionally, an infiltrating high-grade primary brain neoplasm should be considered. Finally, we should consider this all being due to a primary vascular process such as arterial or venous thrombosis. And of course, there are many other rare conditions out there to include, but we have to start somewhere, and in the absence of any other history or workup, I think this is a pretty good starting point. Now, while we could just hit sign report and let the teams figure it out, I think we can do better here, elevating some diagnoses, minimizing or throwing out others, and raise question of some pathologies that the primary teams may not be thinking of. So let's start with the infection category, focusing on bacterial infections. If this were a bacterial meningitis or encephalitis, one thing is almost certain. These patients are sick, right? They aren't calmly walking into the hospital with some odd neurologic symptoms. They're septic, have rigors, and signs of infection on physical exam and labs, keeping in mind that immunosuppressed or immunoincompetent patients may not be able to mount a vigorous immune response. We expect to see features of meningitis and cerebritis, and bacterial infections are dirty, producing abscesses and pus, best proven on our restricted diffusion sequences, and which we did not see in this case. Diffusion-weighted images showed mostly T2 shine-through from all the edema. Maybe we call down to the ED and discuss the patient more, and they confirm. The patient is non-toxic appearing on exam and without signs of sepsis, so we're going to downgrade this etiology. What about viral etiologies? While this is again broad and your considerations will change depending on the history and if the patient is immunocompetent or not, there happens to be a certain genus of viruses that have a predilection for the deep brain structures and brainstem, as we see here, sometimes also involving the cerebellum. These are the flaviviruses, a group of viruses including dengue fever, West Nile virus, Japanese encephalitis, tick-borne encephalitis, St. Louis encephalitis, and others. One thing that is odd here is that these viruses typically present with bilateral involvement, whereas our findings are primarily left-sided. Again, we would expect to see some evidence of active infection and inflammation on labs, as well as clinical findings of encephalitis such as altered mental status and neurological deficits. So we're going to give a viral etiology, possibly a flavivirus, a thumbs up on our differential. Now we consider some atypical infections such as TB. TB can look like just about anything, but classically, it has some degree of meningeal involvement, typically peel thickening on the surface of the brain or brainstem with enhancement, which we don't see here. And of course, you'd want to correlate this with the patient's history and chest imaging to see if other evidence of TB is present elsewhere within the body. We'll take a look at an actual case of TB with neuroinvolvement in the future, but for now, we throw our hands up in the air and include it for the differential of any inflammatory or infectious process within the brain. One interesting thing gathered in the history is that the patient is from the Middle East. Cleaning this up, we've at least been able to favor a viral etiology over a bacterial one, and we'll bring up TB at the end of the differential. Moving on to our next group, autoimmune, and starting with demyelination. While many processes can cause demyelination, the big players we are typically referring to, especially when we both have brain and optic nerve involvement, are disorders such as multiple sclerosis, neuromyelitis optica, and others such as anti-myelin oligodendrocyte glycoprotein, more commonly referred to as anti-MOG. You could do a whole talk on imaging findings that favor one over the other. Of note, spine imaging was performed to look for other sites of involvement, but the study returned normal, which does not exclude demyelinating disease but may have helped further refine our differential. But what was interesting is that an eye exam was performed, and the patient was found to have evidence of uveitis on the left. So we're giving demyelination a thumbs up. Now let's talk about vasculitis, another topic that deserves its own lecture. The classic history of a vasculitic process involving the brain is multifocal infarcts in different vascular territories, sometimes of varying age that can be easily written off as atherosclerotic disease, and in more aggressive forms we can see enhancement, edema, and hemorrhage like in our case. On angiographic imaging, we may see luminal irregularities from the inflammation within the vessel wall, and at some institutions we can do what's called vessel wall imaging, which actually lets us see the enhancement from the vessel wall inflammation directly. The most sensitive form of imaging to visualize a CNS vasculitis is a digital subtraction angiogram, which is better at visualizing those distal arteries. Clinically, patients can be altered, have neurological deficits, but usually aren't toxic appearing like our bacterial meningitis patients. While there are many different causes of vasculitis, one we have to mention here is Behçet's disease, which is known to have a predilection for the deep brain structures and brainstem and can concurrently present with uveitis. Of note, in our case, both the CT and MR angiographic imaging were performed and negative for evidence of vasculitis. But more importantly, just because the vessels look normal on imaging does not mean we can exclude it on our differential. It may just be affecting too small of vessels for us to see directly on imaging. So we are most definitely putting vasculitis on the differential for this patient. Now let's talk about neurosarcoid. Like TB, it's a great mimicker of many different inflammatory processes, and also classically you'd like to see some leptomeningeal thickening and enhancement, which we don't see here, but that doesn't rule it out. One important thing to know is that it would be rare to have a neurosarcoid presentation alone. Remember, this is a systemic disease that commonly presents elsewhere within the body, so if you're thinking neurosarcoid, you should go searching for it in other places. And like TB, you can never go wrong when including it within your differential for a weird inflammatory process. So we'll throw our hands up for this one as well and put it later in the differential. Alas, there are many other rare and odd autoimmune processes this could be, but we do the best with the limited information available, and I think that this is a well thought out initial differential to give. Some of you out there might disagree with me, but that's okay. So we didn't eliminate much from the autoimmune category. This is pretty suspicious for an autoimmune process. Let's move on to neoplastic etiologies. We have these multifocal lesions, but there doesn't appear to be significant mass effect associated with it, a hugely important fact. Whenever you see a lesion in the brain, you have to ask yourself, is there mass effect or not? In this case, not. So that rules out many masses, but there are some particular ones worth considering. The most suspicious of these being lymphoma. Lymphoma can appear anywhere in the brain, usually avidly enhances, and can be multifocal. It also doesn't have to show significant mass effect on the adjacent tissues. One thing that doesn't quite add up here is the lack of restricted diffusion. Lymphoma is a bunch of packed cells and pretty reliably shows restricted diffusion, but regardless, remains our top neoplastic differential consideration. An infiltrating high-grade glioma is also a possibility, but less favored as again there seems to be little mass effect and no evidence of necrosis. So we might include it toward the end with TB and sarcoid. Finally, let's talk about a thrombosis or thrombi causing infarction. Subacute infarction is a commonly overlooked etiology when we see a process with edema and enhancement. But always keep in mind that subacute infarcts are inflammatory. The tissue has died, and the body brings in products of inflammation in response, so subacute infarcts can enhance. However, this does not fit an arterial distribution, nor does it look like a typical pattern of embolic infarcts, which you typically see more peripheral. Plus, we already performed a CTA head and neck which was negative, and there was no diffusion abnormality on the MRI to show evidence of acute or subacute infarction. So we can exclude an arterial infarct. One even more commonly missed etiology you should always think about when you see edema and enhancement within the deep brain structures is a venous infarct. Time and time again, these are missed on imaging, and people have gone on to get repeated brain biopsies, returning as nonspecific inflammation, until finally someone figures out that they have a venous infarct from a missed thrombosis. The nice thing is if you have a 3D T1 Bravo or MP-RAGE post-contrast sequence, you can take a quick look and tell on our study that the internal cerebral veins and other deep veins are patent. So we can also exclude venous infarct in this study. Putting it all together, you can see we've come up with a nice, thoughtful differential here that can certainly give the clinician some immediate pathologies to think about and start treatment if one seems more suspicious than the other. So what did they find? As we said before, the patient is from the Middle East. They saw evidence of uveitis on the eye exam, and we saw optic pathway involvement on imaging. They appropriately did a large panel of labs and blood cultures, which turned negative for bacterial infection. Perhaps most importantly in this process, they did a spinal tap and CSF was collected, which is a must in this case since we're considering bacterial and viral CNS processes as well as autoimmune and neoplastic processes. Surprisingly, other than showing a nonspecific inflammatory pattern, it all returned negative. They even went as far as to perform a PET exam, trying to figure out if this was a hyperbolic lesion suggestive of lymphoma, and it returned the opposite. This area was actually hypometabolic, making neoplasm unlikely. And critically, additional lab studies showed the patient was HLA-B51 positive. So we've ruled out infectious processes, we've ruled out demyelinating disease and neoplastic etiologies, and this, in conjunction with the HLA-B51 finding, leaves us with the diagnosis of vasculitis from Neurobesset's disease, which has a predilection in the Middle East population, can be seen with concurrent uveitis, and has a high association with HLA-B51 positive patients. Now, you may be a little skeptical that anyone could guess this was Besset's vasculitis on the initial imaging, and that this may be a luxury of hindsight. But believe it or not, this in fact was raised in the initial differential and very well may have led the primary team to assess the patient for that HLA-B51 antigen on the workup that was key in this case. This patient was put on immunosuppressive agents, and their follow-up study half a year later showed resolution of the enhancement and edema within the deep brain structures and midbrain as previously seen, with some residual T2 hyperintense signal, most likely representing gliosis as a result of the prior injury. Thanks for following along with me in this case. I hope you learned something, and we'll see you for the next one.